Welcome to Medical Myths, Legends, and Fairy Tales. I'm your host, Dr. Alan Christensen. Look, you know that between the latest online fads and the crazy media headlines, it's easier than ever to get confused about your health. And you and I just want to feel better and live longer. We want to know what works. And we can't wait for further studies. We need to make decisions today based on the best evidence we've got. Well, that's exactly what this show is here for. So let's get to it.
Hi there, this is Dr. Linda Kashaba from Integrative Health. Would you like some help with your thyroid? We would absolutely love to help you out. And guess what? We can even do remote care. Please call us today at 480-657-0003 to set up your first appointment. If you mention code podcast20, you will get 20% off from your first visit. That phone number again is 480-657-0003, and the code is podcast20. Can't wait to meet you.
Hey, Dr. C here with you. So leaky gut, is that a real diagnosis? You may know there's some controversy that the alternative side puts a lot of thought into it, the conventional side does not. But how can you say there's no such thing? I had a fascinating conversation with Tamara Freuman. She's a New York City-based registered dietitian. I came across her because she's the author of The Bloated Belly Whisperer. You know, it's a book I stumbled across just browsing the library. I was looking at the new health titles, and I really enjoyed her book. And I reached out and wanted to talk to her about this. And I also talked to her in the near future about hypochlorhydria. She's got a master's degree in clinical nutrition from New York University, and her practice specializes in digestive disorders and healing those through diet. So we go deep into this whole idea of leaky gut, what we do know about intestinal permeability, how it relates to some diseases but may not be causal. But it was pretty fascinating stuff that she shared with me. And I looked at a lot of the references and read through them and had some real revelations. So enjoy Tamara Freuman. Hey, Dr. C here, and I'm joined by Tamara Freuman, and super excited about this. So, Tamara, welcome to the podcast.
Thanks for having me.
Yeah. So, I read your book. This was earlier in the year, and I'm getting my notes back up. Yeah, The Bloated Belly Whisperer. Clever name, and I love the book. And the discussion you had about hypochlorhydria and how it's often misunderstood. That's what first prompted me to reach out to you. And we talked back and forth, and it sounded like leaky gut might be even a better topic to go into, at least first though. And when you mentioned that, I looked just a little bit at some of the literature, and I quickly saw data suggesting that the whole leaky gut hypothesis may be just much more of a correlation with diseases and not so much a causation of diseases. And I was busy with plenty of other projects. And I said, well, I'm going to be talking to her soon, so I'll come back to this later. And then this morning, I sat down and read all the things you sent, and really excited. So very briefly, I'm just going to mention what my biases were going into before we spoke prior and before going into today. And then I really want to talk through your material.
Great.
So, yeah. What they would have been before we first talked, I think there's a common idea that leaky gut, these bad things come into the bloodstream, they trigger an immune response. That's how disease starts, autoimmune disease and whatnot. And that if one would do certain nutritive compounds that were relevant cofactors for gut cell repair, that could help to reverse this process. And I more or less took that at face value. I didn't really have a strong attachment to it, but I had no real strong reason to question that. And then your first comments made me really question the relevance of correlation and causation. And the rest of what you've written has caused me to question a whole bunch of it. So your summary that you sent was incredible. I'd love to go through that as you put it together, if you wouldn't mind, just expand upon those topics and mention what this whole thing is, and then come into, how we got off track on it.
Yeah, there's so much. There's so much to unpack there. Leaky gut, or what's really called is intestinal permeability, which is such a mouthful. And so we in popular sort of conversation, it's been called leaky gut. But that is such a complicated phenomenon, and it is so like misunderstood. Because it's so complicated, I think there's a tendency to oversimplify it, and so much nuance gets lost in that oversimplification. And that's where people can really not understand what's happening, and therefore come to, I think, inappropriate conclusions about whether it's something that they should be fixing, and if so, how that would even be fixed. And so there's so much to unpack with it.
So let's talk just a bit about because there really is a phenomenon that happens, and it is a physiologic process, but let's just explain for listeners quickly what that process is and what goes on.
Yeah. So, I mean, I think it's helpful to think of your intestines as they are a membrane, right? Like the inner line of your intestine is a membrane, and it is not completely sort of solid and impermeable, right? Like things can get through it, and things are supposed to be able to get through it. And the degree to which a membrane allows something to get through it is called permeability. Okay. And if you remember back from your 8th grade biology and you learned about osmosis, I mean, if you can remember back that far, your teacher probably talked about how osmosis is when little dissolved substances move across that membrane, right? That semi-permeable membrane. And to some extent, your gut is like that. And so some degree of permeability is normal and desirable. Things need to get from the gut into the body.
And the body has to be able to adjust that in some circumstances. And also it's interesting to see that permeability, there's really two separate things. There's how readily things get in, and then how aggressive the body blocks that. They're like separate processes going on.
Absolutely. And so permeability is something that's not a yes or no question. It's really something that exists on a continuum. How permeable is somebody's gut, and to what is your gut permeable? Those are really the relevant questions, right? And so, to some extent, we need permeability. We need to let some things in. We need to let sodium in. We need to let, water through. We need to let the nutrients that we eat have to get into the body. And so we need some degree of permeability, but we can't let everything in, right? We've got trillions of bacteria living in our intestines, and we can't, just let all of them just into the body, or, quickly that would go bad. And so the opposite of permeability is what we call barrier function, right? And so your gut has to also perform a barrier function. It has to be selective with what it lets through and be a barrier to things that it doesn't want to let in. And so this very kind of this balance of selective permeability and barrier function is really what your gut's job is in keeping the bad stuff from the outside world out and keeping the necessary stuff, allowing that through. And so that's the first thing, is the gut is not either leaky or not leaky. There's sort of this continuum of how permeable it is.
And this can take place as far as things that are absorbed through the cells themselves or between the cells. You've got different mechanisms that way.
Absolutely. And so there's a couple of different ways that the gut allows things in. And they're both normal, right? And so the first one is that through the actual, like that first layer of gut cells, they're called epithelial cells, through the cells themselves, things can get in. And so, for example, the cells will actually selectively uptake certain sugars, fructose, for example. There are actually receptors, transporters that take fructose from inside your gut into the body, so that's how fructose would get in through the cell itself. Little protein fragments would get in through the cell itself. Various vitamins and minerals that your body wants. Iron and vitamin C. Like there are sort of specific pathways that come in from the gut through the cell into the body. And that is the primary pathway for most things, including most nutrition stuff, proteins and sugars and things like that. But to a secondary degree, other things can pass in between the cells that are kind of lined up next to each other. Things like water, right? We don't need special channels for water to have to get through. Water can kind of slip through, and small little ions like sodium. And that's really important to keep your hydration status and to keep your fluid balance. The fact that electrolytes can kind of flow in and out. These tiny little molecules, that's really helpful for those things to be able to flow somewhat freely in between the cells. And tiny little sugars can also flow somewhat freely in between the cells if they're kind of lined up side by side. And these small little particles in water can just kind of flow freely in between the cells, but very selectively. Large, huge molecules can't. Bacteria can't. So certain things can flow through, but in a selective way. And both of those are really normal. And what keeps the large things out are these little junctions between the cells. I've seen them described in the literature almost like purse strings, right? Like these little protein connectors that keep the cells kind of lined up really tightly next to each other. They're called tight junctions. And the tight junctions kind of keep the cells packed nice and tight so that very large things, bacteria, intact proteins from food that haven't been broken down, those things aren't supposed to be able to just kind of flow through the cells.
And the idea is that can change. There are circumstances that have come up in which this whole process can become altered.
Yes, exactly. And that's what researchers are referring to when they talk about increased intestinal permeability. When those channels in between the cells are allowing more stuff than they should to flow freely in between the cells, that is a case where you have increased intestinal permeability. And again, this is something that exists on a continuum. So it's not like you have permeability or you don't have permeability. It's really something that you measure. Is it abnormally high, or is it higher than your baseline, or is it, kind of within that normal range? And so it's not a yes or no question. It's is it increased or is it sort of normal? And there's all sorts of things that can cause that increased permeability. And so much of what's happening now in the research science is just even trying to understand what those things are, right? We've identified some of them, but this is such an emerging and complicated area of science that we don't fully know everything. We know that certain types of foodborne illnesses or bacterial infections can cause increased permeability. And so, if you have like an acute bout of gastroenteritis from, like E. coli, or, from an infection from, bad meat or things like that, I mean, certainly that can cause more permeability. And I think one of the better studied causes is inflammatory bowel disease. So Crohn's disease is the area that's, I think, been studied the most, where we see that the inflammation from Crohn's disease can actually increase permeability. Some of the inflammatory messengers that our body creates can cause that permeability. And the question is whether the permeability causes the Crohn's disease, or whether it is a function of the Crohn's disease, or whether it's kind of this cycle where a little bit of both is happening. The researchers are still really trying to understand that.
And one of the most counterintuitive things, we'll go through that in more detail, but one of the most counterintuitive things I came across from what you sent me is that there's a little data saying it might even be adaptive.
Yeah. And exactly. And I mean, which is such an interesting thing. I mean, that really speaks to this idea that we don't fully understand this phenomenon, and we don't even really understand, what percentage of people are walking around with increased permeability and they're perfectly fine and they never know it because nobody's checking, right? And so I think it's always for me like this really important point of caution that when we try to manipulate or intervene with phenomena in our bodies that we don't fully understand, sometimes it can backfire. And there are certain things that look at first glance to be unhealthy or abnormal, but often turn out to be adaptive in some way. And only when we understand it later is it become clear that maybe we shouldn't have really been messing around with it before we understood it. And a great example that I always think of is, years ago, all these athletes were supplementing antioxidants. Because it was thought that like endurance athletes, like you would run or do like all these endurance sports, and it would create all these, this oxidative damage, all these free radicals from all the exercise. And we know that free radicals are bad and they can damage cell DNA. And so all these athletes were taking antioxidant supplements to counteract what they thought was oxidative damage caused by their exercise. Well, as it turns out, years later, researchers found that there's a reason for all those free radicals. And when athletes were exercising a lot and creating all those free radicals, that actually facilitated muscle strength repair and strength building. And all the athletes that were supplementing antioxidants to counteract that were actually not improving their endurance. And they weren't, building more muscle and increasing their strength when they were doing weightlifting compared to people who didn't take antioxidants. And so it turns out that this thing that looked at first glance to be not good, there was a reason evolutionarily that was there. And when we started to intervene before we understood why it was there, it turned out not to be in our best interest. And I think that for me, that's a really great cautionary tale about let's understand this thing first before we understand whether we're even supposed to intervene. And if so, how?
Along the lines of what you just mentioned, even a scarier version of that was a little prior, in which smokers were given beta carotene against the thought that would cut their risks of lung cancer.
Great example. I'm very familiar with that research. And again, it's this idea that sometimes even things that seem commonsensical may not always turn out to be correct in the end and to our best interest, which is why, the importance of evidence and evidence-based practice to really like take our time. And it's so frustrating in this day and age because we want quick answers and we want to make things better and we don't want to wait. Science is slow. Research is slow and studies have to be repeated and then re-repeated before we ever come to some consensus. And it can be really painful if you're kind of waiting for an answer. And I totally understand that and sympathize with that. But, the alternative is if we just kind of start, trying out a bunch of stuff, making assumptions and extrapolations, however commonsensical they seem at the time, sometimes it can really actually do more harm than good.
So I'd love to just briefly expand on the idea of evidence, because I think many who might be hearing this and might have been educated about the alternative leaky gut hypothesis have said, well, these people have evidence. And there's really different types of that. And in many cases, what is passed off as evidence is really hypothesis or speculation. We can see things occur in test tube studies and animal studies, or maybe just studies that occur in the mind. Like if the body works this way, then this thing should happen. And they can be so, they can seem so coherent and make so much sense and be very consistent with many other facts that are known. But what happens in a living system that self-regulates, it often just defies prediction. And you only know what will happen to people when you actually see what happens to people.
Yeah, that's so true. And also I would add to that, which is there's, I think, a disconnect or there's a conflation between intestinal permeability or like leaky gut, like when the gut has more permeability, and what I think in popular parlance is being marketed as leaky gut syndrome. That is not the same thing, right? So scientists have observed and they've measured this notion that the intestines can become more permeable, but that's not necessarily the same thing as what's being marketed as leaky gut syndrome, which is this idea that bacteria or food proteins are actually like escaping the gut and making it into the bloodstream and flowing around the body and, getting to the brain and causing fatigue and headaches. That is not what anybody who studies intestinal permeability is saying. None of this stuff is making it into the systemic circulation. And that I think is a super important thing for people to understand, because if bacteria made it into the actual systemic bloodstream, you would get a very life-threatening blood infection called sepsis. So it's not like bacteria are like slipping out of the gut and just flowing around your body willy-nilly, nor are food proteins, right? If you actually had like pieces of food floating around your body, they would block your blood vessels and you wouldn't make it very far. And so there's this idea that is being marketed that seems to make sense if you don't understand the very complex, digestive physiology, but that's not what's happening with intestinal permeability. And that's really, really important is the first thing.
Let's just go on that point a little bit more, because again, I have no dog in the fight here, but I could hear many people who are strong proponents of this who would say exactly what you said is true, but things like LPS, like fractions of bacteria could absorb, or things like polypeptides, not so much obviously pieces of food, but more so just like larger proteins and peptides that would typically be absorbed. They would argue that that's more so the culprit. What are your thoughts about those responses?
So there is some evidence that some of those types of things, especially the LPS, has been shown to make it into what we call the portal circulation, which is when nutrients or food or whatever, is digested and things, come out of the gut and enter into the bloodstream, they go into a vein called the portal vein, which is the bloodstream. And its first destination is the liver. All of the blood from the gut goes straight to the liver before it makes it to the systemic circulation. Why? Because the liver is the detoxifier and the filter for all the crap that made it through your first goalposts that shouldn't have made it in, get filtered by the liver. And so to the extent that bacterial fragments or bacterial toxins or, food peptides, which are like sort of mini protein chains that weren't fully digested, to the extent that anything that shouldn't have made it into your bloodstream makes it out of the gut, it goes to the liver, and then the liver filters it and detoxifies it and sends clean blood out to the rest of the body. And so that portal vein goes straight to the liver. Your liver is sort of like that backup system that makes sure that anything that snuck past the goalie of your intestinal barrier and then snuck past that second barrier of all those immune cells layered right underneath your gut cells. And if they make it past all of those barriers, then you have the liver catching all, like playing that backup. Because think about it, humans have existed for ever. We didn't get this strong by having like one thin layer of gut cells, and then whatever snuck past it was going to make it into our bloodstream and kill us. Like, we have a lot of redundancies and backup systems for precisely these reasons. And that's what your liver is for, which is why it's so important to protect your liver and not do anything to overtax or harm your liver.
And the comments you sent were great that way too. I've mentioned before about the issues of liver stress from just over-supplementation. And clinically, I've seen so many cases where actually I do retreats on occasion, small group retreats, and I've averaged the number of supplements that participants are taking when they come to the retreats. Do you want to guess what that number is?
Well, if it's anything like what I see in my practice, I would probably say between 2 and 3 dozen pills a day.
Wow. See, I thought I was gonna shock you, but I'm not at all. You're spot on. It was 26.
Yeah.
But I've had scores of cases in which someone had elevated liver enzymes, no explanation, but they were on a long list of supplements, and really no one of the supplements was inherently known to be liver toxic, but in some way it seemed that just that combination was. And so just taking them off of that big list by itself seemed to be helpful. And then you sent a study showing that a fifth of all cases of acute liver toxicity were related to supplementation.
Yeah. Over-supplementation is one of the leading causes of acute liver failure. That's not a joke. Because our patients who take a lot of supplements, these are our patients who are more concerned about their health. These are like extra concerned about their health. People want to do the right thing and they want to be giving themselves the best advantage to be healthy. And so, the people taking a lot of supplements are precisely the people who care the most about health. And it's so ironic. And so, it's devastating to see that stuff that people are doing in order to give themselves the best shot at good health may actually be hurting themselves. And so I think it's really important for the word to get out that like more pills is not better. And there's really not a lot of evidence for a lot of these supplements. And especially here in the US, these supplements are not regulated. We have no idea what's in some of the pills that we take. A lot of these things are coming from Asia. Where quality control is not the best. And, here in New York, the Attorney General, like every so often will do all these audits where they'll pull supplements off the shelf and kind of send them to an independent lab to look for fraud to see like, oh, what's in it and is what they actually say is in it. And for herbals, I think it's typically over 50% of herbals have none of the ingredient that they claim to have. And a lot of supplements will have undeclared drugs in them, steroids, animal-derived things. Some have allergens in them that are undeclared. And so you really often don't know what you're getting when you're taking a pill, let alone taking 26 of them.
That's scary stuff.
We'll be right back after a word from Integrative Health.
We hope you are enjoying this episode of Medical Myths, Legends, and Fairy Tale. This is Dr. Roz at Integrative Healthcare. So often we hear from our patients that their primary care physician has told them that their thyroid and hormone levels are fine and they should not worry. Yet the patients still have symptoms of severe fatigue, thinning hair, and weight issues. Unfortunately, this is too common with thyroid care. The good news is we can help and there is hope. The doctors at Integrative Healthcare, including myself, specialize in naturally treated thyroid, hormones, and adrenal issues. We would love to get you started on the path to ideal health. From the comfort of your own home, we can get treatment from one of the doctors at Integrative Health via telemedicine. Go to integrativehealthcare.com to become a new patient today. Use code PODCAST20 for 20% off of your new patient visit. Again, this is integrativehealthcare.com. Use code PODCAST20. Get back on the road to thriving.
And now, back for more medical myths, legends, and fairy tales.
Something else I came across was in reading some of the reviews you sent was the fact that we don't really have good clinical testing methods for leaky gut, even if we wanted to. There's not really a good consensus on how one could diagnose that apart from research settings.
Yeah. And so again, I would probably use the word measure instead of diagnose.
Sure. Yeah.
But yes, measuring intestinal permeability is really problematic. It's a really, really difficult thing to measure. And all of the tests that are used in research settings kind of have pros and cons, and they're not foolproof. And they seem to, how sensitive they are seem to really vary by the individual. What's normal in terms of permeability for me may not be normal for you. And so my baseline might be higher than your baseline. And so I might get a number on my, urine test that looks super abnormal, but actually it's, that's just how I roll. Whereas yours, might be the same number and it might be really high compared to your baseline. And so we don't really have a great sense for what the average American walking around looks like permeability wise, because it's not like, we have population wide data on this stuff. And so for all we know, what we're considering excessive permeability might be, existing in 35% of the population who are walking around perfectly healthy, fine. And so it's really tricky, A, to measure it, and B, to know whether our measurements are clinically significant or not.
Yeah, I'd love to talk a bit more about what we do know in terms of conditions that seem to overlap or have higher levels of permeability, and then start to walk through just how we're unclear about the relationship between correlation and causation.
Yeah, and so I think that the best studied one is Crohn's disease. And Crohn's disease, the whole idea of causation and correlation is still up in the air. There are some data that do suggest that intestinal permeability seems to precede actual symptomatic inflammation. And so there is this notion that the permeability may actually come before the inflammation. But again, that doesn't mean that it's necessarily causing it, right? That could mean that to some extent, that the permeability can almost be like the canary in the coal mine, that might actually signal that the inflammatory thing is about to happen rather than the cause of it. Because when researchers have looked at the healthy first-degree relatives of people with Crohn's disease compared to healthy people who don't have first-degree relatives with Crohn's disease, we do see increased intestinal permeability in a larger percent of people who have a family history of Crohn's disease, even though they're perfectly healthy and they're walking around fine. And so the question is, genetically, are some people just more predisposed to the permeability, which then you need an extra insult on top of that for it to proceed into a Crohn's disease? That's, I think, one of the more prevailing hypotheses around it, which is, you might have some permeability because of a genetic predisposition. And then if there is an environmental trigger, or you get a virus, or, something in the diet combines with that permeability caused by the genetic predisposition, that's what sets off the inflammatory process. I mean, that's one idea of how it might work in Crohn's disease. Celiac disease is another one where there seems to be intestinal permeability in genetically predisposed people who have actual, inflammation from eating gluten in their diets. And then when they stop eating the gluten, the permeability improves even before the inflammation has. And so again, there's this idea that there's a strong genetic component with celiac disease. Not everyone can get it. You need to have at least one of the two genes. And so is it the kind of thing that if you have one of these genes, you're more likely to have permeability? And then if the gliadin, which is that compound in gluten that triggers the inflammation, slips through during a period where you're more permeable, is that what sets off the disease? That's kind of one thought and hypothesis around the pathogenesis of celiac. But we don't know, and we don't know how to fix it, right? Other than just go on a gluten-free diet, and then everything completely gets better and goes away. And so those are, I think, two of the diseases where we have the best data on the correlation of permeability with disease.
Briefly relative to celiac and expanding upon that, many have seen the data that you mentioned about how those with celiac can have greater permeability. When they go gluten-free, that may improve. And they've looked at the role that zonulin may play in that. And there are a few papers suggesting that those without celiac can still have elevations of zonulin relative to gluten exposure. And many have taken that to conclude that, therefore, even those without celiac can be at risk for problems related to gluten and then all this rest. Can you help us just unpack that a little bit?
I mean, there are literally no data that I'm aware of suggesting that elevated zonulin levels, like in the bloodstream or in the stool, in the average person who doesn't have celiac disease, have any kind of predictive ability as far as risk for health. Like, it's an interesting hypothesis. There are no data to support that right now that I'm aware of. And so there's that. And in terms of someone who doesn't have the gene for celiac disease, or at least one of the genes, the HLA DQ2 or DQ8, it's almost impossible to develop celiac disease no matter how much zonulin you have, right? And so this idea that intestinal permeability in and of itself seems not to cause any disease, it really seems to be intestinal permeability plus certain factors that may be more implicated in disease pathogenesis. And so the permeability in and of itself may again be the canary in the coal mine that something else is going to happen. It may be something that a whole bunch of us are walking around with, but only a tiny percentage of us it's going to cause anything because we have the gene for Crohn's, or we have the gene, for celiac, or we have, the genes for type 1 diabetes. Like, we have that genetic predisposition coupled with the permeability, coupled with an insult, that it takes all three of those things to happen together for the badness to happen. Whereas the permeability in and of itself seems not to cause any disease. And that's been shown in human models and in animal models as well.
Just to close the discussion on zonulin, there's been an assumption that zonulin is somehow a causative factor in a lot of this, that it's present and that therefore if it's high, it's causative. But you sent data, and I also had seen data prior saying that attempts to block the effects of zonulin really had no change in barrier function or disease progression.
Yeah, so a drug was developed called lorazepam, which antagonizes zonulin, or, kind of opposes it. And they were trying to test that in people with celiac disease to see if taking a zonulin antagonist would reduce the permeability, and it failed. So it doesn't seem to be that the zonulin in and of itself was the key factor. Really, what we've seen, the only way to reduce permeability in someone with celiac disease is a strict gluten-free diet. And that seems to work much quicker, very quick. Even when there's still active inflammation, the permeability resolves on a gluten-free diet, even before the gut is healed. In terms of damage, with celiac in particular. And so the permeability seems in celiac disease much more related to gluten intake so far, right? I mean, maybe they will come up with other ways to modulate those tight junctions, but it's tricky because, those tight junctions, they let, fluid and sodium and important, electrolytes for fluid balance through. And so, there's not a whole lot of optimism that you can really take drugs that would manipulate those tight junctions, because if you tighten them too much, then you're going to cause all sorts of other problems with your, fluid and hydration balance. Like, we need those junctions to not be completely sealed to the things that they're supposed to allow through. And so, it's not really clear to what extent manipulating the tight junctions with drugs is going to be a fruitful therapeutic avenue. But, I will leave that to the researchers. I'm the dietitian, right? So it's not my area.
Obviously, these researchers are completely unaware of the power of bone broth.
Yeah, clearly. Clearly they are. Yeah, I mean, I'm glad that you brought up the bone broth idea because, I see a lot of these diets out there, this idea that like our guts need rest, right? We need to go on these cleanses or these bone broth fasts or things like that, because that's what's going to sort of heal a gut that is too permeable or too leaky. And I think it's really important to understand that when you deprive the gut of fiber, especially a very varied high fiber diet, what happens? You're starving the microbiota, right? You're starving all the critters that live there. And what does a fiber depleted microbiota do? What do they turn to for food? They turn to the mucus lining of your intestine to notch on that because they don't have fiber to eat. Your mucus lining of the gut is the first physical barrier to keep bacteria off of the cells. So that the bacteria, good or bad, can't adhere to the gut cells. And when you lose that protective barrier of the mucus lining, you're more likely to have bacteria come into contact with the gut cells. And so this idea that we're supposed to kind of go on like juice cleansers or bone broth fasts or intermittent fasting and these fasting and these like very stringent elimination diets, we're eating nothing but like chicken. This is not a way to nourish the gut microbiota. And this is not the way to maintain a robust mucus barrier in the gut. And so I think that, again, these ideas that seem to make common sense, like, oh, well, if my gut is inflamed, it needs rest. That is intuitive. That feels commonsensical. That seems to appeal to our sense of common sense. But if you understand the gut physiology, starving the microbiota is one of the worst possible things you could do if you're concerned about inflammation.
Something that's always just left me flabbergasted is how these two ideas emerge together. The idea, there's discussion, everyone gets that the microbiota is important, but then also we've had the convergence of that idea along with the low carbohydrate hypotheses. And it's almost like, let's take up gardening, but let's not use water.
Yeah, no, it's important, right? Because now we're seeing all sorts of these diets that potentially that alter the microbiota and diminish them. And so like the keto diets are one that really starve the microbiota. We see kind of very unfavorable changes, not just in the amount of bacteria in our bowels, but also the mix of them. And we're seeing sort of that the ketogenic diet.
The diversity.
Exactly, the diversity. And it may favor some of the less probiotic strains when we're starving ourselves of the types of fiber that we do on a keto diet. Bone broth fast, juice cleanses, very stark elimination diets where people eliminate like entire categories. And so, getting rid of like, legumes and grains and nightshades and, certain seeds, like some of like
nuts and seeds. Yeah.
Yeah. And so all of these things, the more of these categories of fiber rich foods we eliminate, we are selecting for who is living in our gut. If you don't feed them, they don't grow and they don't thrive. And the more types of fiber we eliminate from our diets, the more types of bacteria we eliminate from our guts. So we have to be very thoughtful about some of these very draconian elimination diets that are being thrown around right now.
That is such a huge point. I just want to really emphasize that for everyone, that people often think about fiber as a thing and it's really a category, and you want to get enough, but you also want to get the diversity and the variety in all those categories. And when you cut out all these big food categories, you won't get that diversity. And there's so many great foods people often do leave in, like vegetables, and vegetables are wonderful, but you cannot get the full spectrum of fibers that will cause your gut to thrive once you cut out the categories you've mentioned, the legumes, the whole grains, the nuts and seeds.
Yeah, it's fruits. A lot of people think fruit is too sugary.
Yeah.
And I think that's one of the reasons why fiber supplements have not been shown to have the same benefits as high fiber diets. Even if you get the same number of grams of fiber from a supplement versus from food, fiber supplements don't really nourish much of a gut microbiota. If they nourish anything, it's a very narrow set of species, and some of them don't nourish many bacteria at all. And they're designed that way because the companies don't want them to be too fermentable, because then people get gassy.
Wow.
Right? Because if your fiber supplement made you super gassy, you wouldn't want to take it. And so getting like 20 grams a day from a supplement, which I've seen some people on a keto diet do, is not the same as getting 20 grams a day from 5 or 6 different plant-based foods. It's not the same as far as your gut microbiota is concerned.
Or even getting that 20 grams from just one particular food type, one food type within one food category.
Yeah, exactly. Like all lettuce, like just eating like a giant lettuce salad to get 20 grams is not the same as getting 20 grams from multiple different types of fibers from multiple different types of food. We are selecting who lives inside us by what we choose to eat. Like you're not just eating for one, you're eating for 100 trillion. And you really need to think about what it means to be a good host.
Something else that I just wanted to bring up. People have thought a lot about just the worries of gut-borne infections and wanting to reduce infections in general. My big focus is thyroid disease, and many talk about the issue of possible chronic infections initiating or exacerbating the disease. And in the data you sent, that also talked about the hygiene hypothesis as being a factor with autoimmunity. And I've seen this a lot. This will be a big part of my next book on thyroid disease. Do you want to just mention that and how it's going against what our intuitions are telling us?
Yeah, I think that there's a real difference between like food safety and foodborne illness and, bacterial exposure of all kinds, right? And so, this idea that, why are autoimmune diseases on the rise? Why is food allergy on the rise? Like everyone sees this and we're all freaking out about it, and what's causing that? And I think a lot of people are inclined to say, oh, it's our modern diets and it's the new breeds of wheat and it's all the chemicals in the environment, and maybe. But one of the prevailing hypotheses is something called the old friends hypothesis, which is,
I haven't heard that name before.
Oh, haven't you? So it's kind of like the next generation of the hygiene hypothesis, right?
Okay.
And so the hygiene hypothesis is basically like we're too clean, like we don't get exposed to enough bacteria, right? But the old friends hypothesis is very specific to the fact that humans seem to have co-evolved with certain types of bacteria and microorganisms that played a role in training our immune systems in very young age how to behave themselves. And so, for example, like people had lots of worms and parasites, until sort of modern times. And for most people, these were kind of, they didn't hurt us. Like occasionally they'd get out of control and they would cause health problems, and that would be a really bad thing. But many people kind of lived with them and coexisted with them, and it didn't actually cause harm. H. pylori, a lot of people, this is the bacteria that causes ulcers. Like, many people were exposed to H. pylori like early in life or throughout their lives. And for some people, it caused a lot of trouble, but for many people, it didn't do anything. And, things weren't as clean. And so there's just more exposure to microorganisms in general. People, parents used to chew their kids' foods for them and kind of spit into their mouth before we had sterilized commercial baby food. And so there was probably some viruses that the parents were being transmitted to their kids. Epstein-Barr virus is a good example that when kids get it in infancy or early childhood, they might get like a fever for a half a day. And then you're like, oh, it's just like some passing virus and they're fine. But if we don't get exposed to it as children and we get it as teenagers and adults, we get mono and increased risk for other autoimmune diseases later in life. And so there's this idea that being exposed to certain critters early in life seems to have a very tempering effect on our immune system. Whereas when we grow up, in this like very clean, hygienic, sterile environment that we take antibiotics a million times that accidentally kill all these critters in us that may have been living there, sort of doing their own thing and not bothering us. Our parents are like washing our pacifiers when we drop them on the floor instead of just like throwing them back in our mouths. And, we're not really getting the same exposure to the viruses, the bacteria, even some of the parasites and the critters that human beings have historically co-evolved with. That may be the reason, to some extent, why we are seeing our immune systems completely going into overdrive, because they weren't tamed and trained in those early years by these somewhat benign presences that we co-evolved with. And so, there's a great book that I love to tell people about. It's called Epidemic of Absence. And it really traces the epidemiology of a lot of this stuff in such a fascinating way. And it really, I think, expounds upon the old friends hypothesis in a really compelling way. And so I always recommend that to people who are interested in learning more about autoimmune disease and how it might be related to gut health and our environment.
And I guess the difficulty about that is that there's not so many leveraging points that it leaves us just yet. There's no real good ways we have to make use of going back and undoing what didn't happen in early life.
Right. As adults, no, but as parents, yes.
Sure.
Right. And so, I've got young kids. I didn't know a whole lot about this stuff when my kids were little, but I had twins. And so my hands were just full. And so when my kids' pacifiers dropped, they went right back into the mouth. I didn't have time to wash anything. And if a kid found a Cheerio on the floor in the playground and shoved it in their mouth, okay, it's floor dirt, 5-second rule, it's fine. I wasn't like the hand sanitizer mom. I didn't have time for it. I was just so overwhelmed. And I feel like, now that I've learned a lot about the research, I'm like, oh, thank God, that worked out well. Not being super, super germophobic with our kids is not a bad idea. Having pets may not be a bad idea. Letting them play in the mud and, oh, that's so muddy. Don't touch that. That's dirty. Don't touch that. It's okay. Touch it. It's fine. Mud's not going to kill a kid. Being exposed to, farm animals and petting zoos and mud puddles and gardening and that's good stuff for kids, and not being super germophobic is, I think, a good practice for us as parents.
So I'd like to just do a quick recap about the main points we're making here, because this is really going to be new stuff for a lot of people and really shocking and really disconcerting. It's a funny thing. There's the word disillusion, and we use it to say something that it's often used to connotate something that we're disappointed about or saddened by. But when you think through it, you're breaking an illusion, And so when I started looking at the data you sent, it started to light me up. I said, hey, look, it wasn't an idea I was deeply entrenched to or highly identified with, but I was loosely carrying. And I was seeing now that there were some illusory aspects to that. And it was encouraging to me. That was a positive thing. But this may be a lot to swallow, no pun intended for some people. So the typical premise is that, I shouldn't say typical, the common premises or beliefs that are occurring in a lot of natural medicine circles is that varying things trigger this permeability, which they believe to be low-grade infections, dysbiosis, gluten, even for those that don't have celiac. Once this process starts, big things come into the body that should not. They move around, they trigger immune responses, and they start chronic inflammatory reactions, and they trigger autoimmunity. And the partial truth is that there are disease states which include celiac, in which we do know that there can be permeability levels that are greater than they are in other populations. But so far to date, it doesn't seem that conclusively that that's actually causing the disease or that reversing it would reverse the disease process. And it does seem that as disease processes themselves, like inflammatory bowel diseases, as they get better for whatever reason, even without directly addressing the permeability portion, the permeability gets better as the disease does, rather than vice versa. So what else would you add to that summary?
I would add that permeability in and of itself is asymptomatic. And so walking around with increased permeability, if you even know that you have it, that in and of itself is not symptom producing. People like I'm thinking about the healthy relatives of the people with Crohn's disease who didn't actually have Crohn's disease are walking around with permeability. They're not fatigued. They're not bloated. They're not constipated. Like that, the permeability itself does not seem to create symptoms. And so when I have a patient that comes to me and they're constipated and they're bloated and they're, they've got joint pain or they're exhausted, I believe that you have those symptoms. I would like to help you figure out what's causing them because I am not aware of any data that suggests that intestinal permeability causes any of that stuff. And so I always believe my patient when they tell me, I feel this, I experience this. I'm just very skeptical when they come to me and they've told me that it's because I have leaky gut and I need to take, all of these herbal antibiotics and these probiotics and this and that, and I can't eat these foods because they're inflammatory. That's the part that I will question. Especially because if they've come to me, it means that they didn't get better on those protocols. Right. Otherwise, they wouldn't be seeing me. And so it's kind of like, it's not working for you. Maybe it's not what you think this is. Let's figure out what's actually causing these very real symptoms that you are experiencing. And I mean, almost always we find a reason that has nothing to do with intestinal permeability. And so it's pretty rare that a patient will come in here that between me and, a terrific gastroenterologist who I work with, there's a couple of them, between the group of us, we can usually figure it out with some not particularly esoteric, evidence-based, sleuthing. And the trick is really to listen to the patients. And I think a lot of people have been really turned off by sort of Western doctors who practice evidence-based medicine, not because the science isn't valid, but because the way that it's practiced is so rushed and dismissive. And I've got 5 minutes with you because I have to see 50 patients this hour to do whatever. And no good patient outcomes come from that rush process. We have to talk and we have to listen and we have to take very full histories and hear the story behind all this and when did it start and what makes it better, what makes it worse. And the clue is usually in that give and take, that really detailed history and conversation. And that takes time. But if you can do that, the answer almost always reveals itself to be something other than leaky gut.
That's wonderful. Beautiful summary. And another step I'd really encourage for anyone who's struggling with these things or sorting it out would be to go pick up The Bloated Belly Whisperer. This is a really good book. I've not seen anything like it for some time, if ever, as far as really walking through the common symptoms people are struggling with that cause the gas and bloating and giving you some good ideas on how you might start to troubleshoot those and what kind of assistance you might need for that. So any closing words for the listeners, Tamara?
Well, thank you for the little pitch. I'm glad that you found my book so helpful. And what I would say to people is that, bloating might be something that a lot of people complain about, but it can be caused by many, many different things, even though we use the same word to describe it. And if a friend of yours was bloated and they tried a certain thing that worked for them, that same thing might not work for you because your bloating may not be caused by the same exact thing as your friends. And so solutions are not one size fits all. And it's super important to really get an individualized assessment and understand what's going on in your body, because your diet might be really different than somebody else's diet. There's no one right diet for all of us to eat. Different bodies need to be fed differently depending on how they operate. And so to kind of walk into it a little bit flexible, not so dogmatic about this is bad, this is good, but what's good for me and what's not great for me, I think is a more fruitful way to approach diet change and symptom management, rather than kind of adhering to very sort of rigid dogmas about, what the internet says or what so-and-so says.
This has been awesome. I really said about this podcast because I've seen so many examples of things to where, like we're saying, people get ideas based on preliminary data, then run with that. And I've seen that so common in natural medicine. I wanted to reverse some of those. And I'm really excited this process helped me reverse an idea that I was holding myself. So thank you again.
Oh, I'm so pleased. I was really happy to be invited and to have the chance to talk with you. I know that we come from different sides of the world of medicine, but I think that, there's a lot of paths to a good place and there's a lot of paths to truth. And I really appreciate what you bring to the table and what you're trying to do here.
All right. So everyone, thanks for being with us. Dr. C with you. I'm back again real soon. Take great care.
Hey, Dr. Christensen here. Thanks so much for joining me for another episode. Is there a topic you'd like me to cover? I'd love to hear from you. Just go to Dr. Alan Christensen on Facebook or Instagram, write your question, and use the hashtag #MedicalMyths. Did you find this show helpful? If so, please take a minute and leave us a rating on iTunes so that others can know. Thanks much. I'll be back with you real soon. Bye-bye.